I think it's time to begin. Good evening to everyone. We are very pleased to have tonight two speakers instead of one, so it's two for the price of one. Both of them are from Washington, D.C. and London, UK-based Global Development Center for Global Development. It's Michael Clemens and Thomas Ginn. Michael is Director of Migration and Displacement and Humanitarian Policy at the center. His PhD is from Harvard, Bachelor from Caltech, and Master's from Johns Hopkins. He published in high-ranked journals. Thomas' PhD is from Stanford, and Bachelor is from University of North Carolina, Chapel Hill. Tonight, they'll be presenting a paper on global mobility and the threat of pandemics, evidence from 3 centuries. So, Michael, Thomas, welcome.
Fantastic. Thank you all so much for being here and for having us. It's a pleasure for sure. Can everyone see my screen?
Yes, we see it. Go ahead.
Fantastic. All right. So, as we said, we're going to present our paper, Global Mobility and the Threat of Pandemics, Evidence from 3 Centuries. So we know about the many large benefits of international mobility. You think about migration, tourism, business travel. I don't think we need to convince this audience of those benefits of international mobility. And one potential negative externality that we're in the current environment all been made very salient of is the negative externality, potential of risk of spreading an infectious pandemic disease. And we're kind of heightened in tune to this now as COVID is obviously affecting everyone around the world, but this externality can be true at any time, including when we don't know that a pandemic disease is spreading, that anyone could be patient zero, any arriving traveler could be patient zero in another country. And so this externality exists at any point. And so we're going to be studying the association between arriving travelers at a home country and the final size, the total number of people affected by a pandemic once it's run its course. And so the policy question, the question we want to think about here broadly is whether permanent limits or Pigouvian taxes on international mobility, but again, in normal times, before we know a pandemic is circulating, would these permanent limits raise welfare? And so we want to emphasize for sure that we're not talking about emergency or temporary travel restrictions that have been kind of the most talked about or the most implemented so far during the current pandemic. There's a large public health literature that argues that these are largely ineffective, but that's not what we're going to be studying here today. Instead, we're going to be asking whether, think about 2023, when hopefully this pandemic is behind us and we're back to a world in which we're not worried about a pandemic that we know about, whether that international travel still conveys a negative externality on countries for the next pandemic. And so you'll hear, kind of think about some of the narratives in the media, even among academics and policymakers, will hint towards this. And once you start kind of listening for it, you'll hear many kind of arguments in this vein. And so we're thinking about this in a kind of public economics lens of think about whether limits on travel should be analogous to speed limits, where the benefits of you personally arriving faster or analogously you personally being able to travel, how to balance those with the risk that potentially poses to other people's lives. So one example of kind of asking this question is from well-known economist Joachim Voth that notes it's not obvious that running the risk of coronavirus outbreaks every few years or worse is a price worth paying for multiple annual trips to, say, Paris and Bangkok. Severe restrictions may well be desirable and justifiable, bringing to an end a half-century of ever-increasing individual mobility. And I want to emphasize here that he's referring to permanent reduction of international mobility to mitigate future pandemics, which is exactly what we're going to be talking about today. And so in this paper, we're going to argue that pre-existing international travel does not increase the total number of domestic infections once a pandemic has run its course. And we're going to follow the epidemiology literature to call this the final size. So once the pandemic has been declared over, the total number of infections or deaths. And so In order to do that, we're going to present a model based on the standard susceptibility infectious recovery framework that I'm sure some of you all are familiar with. And we're going to use this very simple framework to argue that lower levels of travel lead to a later onset of the disease, as you would expect, and kind of consistent with intuition, but that the delay is minimal. And that's going to be kind of a key component here. Now we can think about, okay, if we could delay the onset of a disease in this way, how would that then translate into the final size of the disease? And we're going to argue first theoretically and then empirically that would be independent of the final size. So whenever the disease starts, the domestic factors are going to be really what determines what drives the final size calculation, the total number of people affected. And so you put those two together, and this implies that if you were to stop travel at onset, so let's say that emergency travel restrictions are totally effective, then the expected final size is independent of the prior level of travel. Now, a question that kind of the natural follow-on question is, if travel continues during the pandemic, what would happen? And then we're going to extend the model to say that the effect of travel on the final size is actually ambiguous, that it could, consistent with many people's intuition, increase the total final size. It could also decrease the final size, as we'll go through, but overall, we're going to argue this is going to be small for any plausible parameters. So then we're going to take this model and we're going to map it onto the data. And we're going to look at pandemics from 1889, 1918, 1957, and 2009 that we can get all of the required data for. These are all influenza pandemics. And we're going to evaluate as many of these predictions for these pandemics as we can. We're then going to take global mobility data from 2008 to be able to evaluate the H1N1 pandemic as detailed as possible. And so to preview at the country level, what we're going to find is that think about a draconian 50% reduction in travel. And this includes both incoming foreign travelers, but also returning citizens, immigrants, anybody like that. 50% reduction would delay onset, but only by about 1 to 2 weeks. Then we're going to take that next step and look at how that onset date correlates to the number of deaths that we're able to measure, and we're going to fail to reject zero correlation between the onset dates, so not be able to establish any statistical relationship between the date and the total number of deaths. And then for, again, H1N1 in 2009, we're going to fail to reject this any statistical observational relationship between travel and deaths in that pandemic. And so the implications is that, the arguments for potentially reducing international mobility based on the argument of mitigating future pandemics would have enormous costs, but essentially no benefit for the objectives that it's seeking to achieve. And so returning to our original analogy, that this would be more analogous to speed limits on passenger airplanes, where you may be very worried about dying from in a kind of air accident, but if we attach a speed limit there's no evidence that would kind of have any effect of reducing the probability of a catastrophic event there. So that's kind of to summarize the paper, and now I will go into a little higher level but deeper dive into the model. So we're going to be looking at how, again, can pre-pandemic mobility affect the final size, the total number of people affected by the pandemic. And so in our base model, we're going to be thinking about emergency travel restrictions being implemented when the disease arrives in the home country, and those being completely effective as a kind of thought experiment here. So this first point in the chain here is the effect of mobility on the onset date, and then we will look at then mapping onset date into the final size.
Sorry, Thomas, one quick clarification question.
Yes.
So when you can you go to when you say travel restrictions are implemented when the disease arrives, so you mean after there have been some cases detected, you put some restrictions?
Exactly. Yeah. So think about this as the first domestic case. So you allow travel, you can't observe what's going on in other countries, you can observe what's going on in your country. And so once the disease arrives, then you are you can stop future travel, but there's at least kind of one patient zero that makes its way at any point into your country.
Okay, thanks.
This is like the December 2019 or the first half of January 2020, the world we lived in then.
Yeah, cheers.
Great.
Okay, thanks.
So just a quick notation. So I is going to be the infectious, and then the I star is going to be the proportion of infections in the foreign country. So star for the foreign population. And then M being the number of travelers. Think about this. We're randomly selecting travelers out of this total foreign population, and those travelers are independent of health status. You can think about them not knowing that they're either have the disease or there's kind of not being the robust enough test to be able to perfectly screen out infected travelers. So you have M travelers and I star proportion of the infected travelers. And so then thinking about the probability of at least one infected traveler arriving to your shores in period T is 1 minus I star of T raised to the power of M. So very simple model to get us started off here. And then we're going to take this as the parameter for a non-homogeneous Poisson process in a wider model to then think about how in each period, how this then maps to the arrival date of when we would expect the disease to arrive. And so then this is going to show that an increase in travelers consistent with intuition is going to increase the probability in every period. And then that's going to lead to a faster expected arrival. But the key takeaway here is the magnitude. So here on the x-axis, we have the number of arrivals. This is M in the model, and this goes from the highest number of daily arrivals, which is China, close to 500,000, to the lowest, some small Pacific islands, to as few as 50. And then on the y-axis are the days until the onset in the home country. And so 3 different lines corresponding to 3 different infectious rates of disease. So how far the disease spreads. This is either R naught, as you may have heard, kind of the proportion of the infection from one disease transmitted to someone else, or the doubling rate D here. But either way, we see that across each of these hypothetical diseases, that this is downward sloping, consistent with intuition. But the slope is shallow for all of these, that no matter how many arrivals you have, that you're not going to save many days here. And you're going to save even fewer days. This black line, the more severe the disease, the faster that it's spreading relative to a slower moving disease. But overall, it's going to be a short savings in the time scale in general. Another way to look at this is this graph, where on the x-axis now is think about reducing your travel from whatever percentage it is, whatever absolute number it is beforehand, reduced by a certain percentage, and then how much the delay that would buy you in terms of the disease arriving. And we're going to find again here that that's going to be very small unless you get to something like 90, 95, even higher percentages of people being screened out. And so the main takeaway here is that the disease is traveling, it's exponentially growing at the initial stages. And so there's just not any reduction in travel is just not going to buy you very much time at all in terms of the disease arriving. So then we're going to take that short savings. There's savings in the onset date, and now we're going to see whether those savings, as short as they are, could potentially map into savings in terms of the number of deaths and the final size from the pandemic. So here's where we get into the SIR model, the susceptible percent susceptible, percent infectious, and percent recovered is going to be a system of differential equations that maps this these transitions between the numbers that are susceptible to infectious, which is the susceptible times beta, which is the transmission rate from infectious to susceptible, and then the transition from infectious to recovered, which is this parameter gamma. And so the numbers that are kind of moving from susceptible to infectious is this S beta I, and then the number moving from infectious to recovered is gamma times I. And so R naught is then defined as the number of infections in an all susceptible population that's generated by one infectious case. I'm sure you've heard this number in the news, and in the model, that's just beta divided by gamma here. And so when you calculate this out, the final size is the proportion of the home population that's infected during the pandemic once S is taken to infinity here. So S at time infinity. And when you work this out, it's 1 minus e to the negative r to the power of f. But you'll notice that there's no t, in that in this equation. And so the expected final size is independent of the start date, which is a very classic result from epidemiology dating back to the original model in 1927. That was one of the first uses of this model, was to argue that the expected final size is independent of the start date for the home population.
Thomas, can I just say, an epidemiologist translated that equation into English for us as, once the pathogen arrives in your country, it does whatever it's going to do.
Exactly. So we're mapping here mobility to onset date, and we theoretically would expect a relationship. And then onset date to final size, we're in a base model not going to be finding this kind of direct relationship here. But you can imagine extending this model to where potentially relaxing R naught to vary over time. So relative to the global onset date, but maybe getting hit with the disease much sooner, or even just a little bit sooner, means that that the death rate is higher, that the infectious rate is higher. And so if you allow R naught to vary, you could imagine some of the overall findings of the model reversing. Then you could think about travel facilitating the spread of ideas, technology, workers, and supplies for prevention and treatment. So if we were to reduce the number of travelers, that would potentially have a negative effect on R naught and our ability to fight the pandemic once it arrives. And so on that dimension, you could think about travel reducing R naught. And so overall, there's many stories that you can tell, but that that we're happy to kind of allow for an ambiguous theoretical prediction, and that will lead to the empirical test that Michael will talk about in a minute. The last extension that I want to talk about really quick is, again, if you allow travel to continue during the pandemic, but again, there'd need to be some kind of mapping between pre-pandemic mobility and during pandemic mobility, maybe because there was more pre-existing travel, that it's harder to slow down travel during the pandemic. But let's, for the sake of argument, say that that's potentially going on here, and what would that look like in our model? So returning to the SIR framework here, now we're going to make the infections a weighted average between P, the proportion of travelers that are in the home country. And this is, think about this as the probability of interacting, of a home citizen interacting with the travelers. You have travelers that are coming in every period, and they're P% of the population. And so that's P times I star, the proportion that are infected in the foreign country. And then 1 minus P, the rest of your interactions are with I, the number of infections in the home country. And so then letting the model run from there. But you can think about this P, in our data, the median country has 1.5% of people within the country boundaries as being abroad within the last 10 days. So as one benchmark here. And then final size F prime in this model would again just be taking this weighted average and raising it to that power. But what would this actually look like in practice? So think about the incoming traveler, travel coming in from a country where F star is 0.58, which corresponds to R naught of 1.5. So here, so F star is the final size in the foreign country. Now we're going to have 4 different versions of this model, where F is the number, the final size in the home country without any travel, if it was in autarky and a bubble. So in that world, if you and then the proportion of travelers here is on the x-axis, and increasing from kind of 0 all the way up to 10% in the population, and then the increase in final size from this number here on the y-axis. And so the first one to look at is this orange line, and this says that if you're going from an infected country of 0.58 and to a home country of 0.58, that the increase in final size is going to be 0, that there's not, the weighted average is going to be the same as the kind of individual components of that average. Now, consistent with intuition, if your final size was going to be lower, so 0.42 less than 0.58 or 0.18 lower than 0.58, you're going to have a higher final size, but these magnitudes, think about 0.01, 0.02% of the population, it's going to increase your final size, but not by very much off this base of 0.5 of 0.58 here otherwise, or 0.42 or 0.18. Then if your final size was going to be higher than the final size in the foreign country F star, so your final size is going to be 0.69 and the foreign country was kind of 0.58 by the end, you're actually going to decrease your final size. You're going to be thinning out the population overall of people that you could potentially bump into that would transmit the disease, and you'd actually lower your final size. Think about you know, the US with very high levels of the disease being transmitted right now. If people from New Zealand are coming to the US right now in large numbers, it's actually going to be beneficial, or even China where the disease started and it's transmitting much less right now. So ambiguous predictions overall if travel is to continue during the pandemic, but the main takeaway is that this would be small. So now we've kind of gone through the model overall. So mobility could affect onset date, but in small ways. We're allowing for it to be ambiguous between the onset date effect on final size, and then potentially ambiguous between mobility's direct effect on final size, which brings us to the need for empirics. And so then the last slide I'll go through is some of the data that we're looking at. So on pre-pandemic mobility. So the first data we're going to pull together is from the United Nations World Tourism Organization. And this is going to be from arrivals across land, air, and sea as reported by these national governments. We're going to do an exercise to impute the missing values, but this is going to be a small percentage of the total. And we're going to use 2008 as the year preceding 2009 when H1N1 was really taking hold in order to look at, again, that pre-pandemic mobility's effect on the final size of H1N1. Then we're going to add in migration flows as a recent estimate by Azzoz and Rafferty here to supplement this UNWTO data. And this is going to combine the short-term travelers, migrants, and returning residents in order to get the daily flows to each country, which range from 67 in Tuvalu per day to, like I said, 447,000 travelers arriving to China each day. And just our interest, most of our work is on migration, not specifically on travel. And so we've been particularly interested in the migration piece, which we found interesting in these data account for in 2008, 0.8% of all travelers, which just means if people want to harp on the potential for migrants to spread the next pandemic, that's less than a drop in the bucket here of the total number of people that could be kind of patient zero among incoming travelers. So I will stop there and turn it over to Michael.
Thank you very much. I'm going to try to share right now. Can you see my screen now?
Yes.
Great. So thanks a lot, Thomas. Thomas set out the theoretical framework, and what I just want to do now is take that theoretical framework to, we claim, all four historical pandemics where relevant tests can be conducted. It's only a subset of all pandemics. There are many other pandemics you'll have heard of that won't be here. And our case selection here is pandemics that went around the world, that caused a substantial mortality in many different countries, and were very rapid onset. So you can see that rules out many. HIV pandemic took decades to spread around the world. So did the Zika pandemic. Middle East respiratory syndrome and SARS 1.0 caused substantial mortality, but only in a handful of countries and not really enough to do statistical analysis. These are the 4 historical pandemics where we can do regressions. So this is starting with the 1889 influenza pandemic, starting either in Greenland or more likely what's now Bukhara, Uzbekistan, then part of the Russian Empire. So it's known as the Russian flu, 1889, and waves in subsequent years. Then the so-called misnomer of Spanish flu of 1918, 1919. The Asian flu starting in China and spreading all around the world, 1957. And as Thomas stressed, the one we have the best data on, H1N1 swine flu, starting in Mexico in 2009 and continuing into 2010. So we're just going to look one by one at the 3 kinds of relationships that Thomas sketched. The first one, the relationship between mobility measured as travel or migration and the arrival time. So we can look at this across space and across time. I'll start with across space. This is just a cross section of essentially all countries in the world with mean annual immigrants on the horizontal axis. The graphs look quite similar with traveler arrivals on the horizontal axis, but this is immigrants. And the vertical axis here is the day that H1N1 swine flu spreading out of Mexico was first reported in each country. And you can see a clear negative relationship here. That is, countries that had fewer immigrants, absolute number of immigrants, and that's what the model predicts, not as a fraction of the population, but just the number of people showing up, that capital M that Thomas pointed out. When there are fewer people showing up, the pandemic arrived later. But you can see both in the linear fit and in a fan regression, fan non-parametric regression in the dotted orange line. So the slope here is really shallow, and it's about 10 or 11 days of delay for each halving of immigration, which is really a very, very large change. So this is really quite similar to the theoretical simulation graph you saw before. Another way to slice this is to look across. Oh, excuse me. This is incoming trips on the horizontal axis here. Travel now instead of immigration, and really the qualitative characteristics of the graph don't change. We can look over time as well, and I think this is one of the more interesting parts of the paper to me, because we gather data over a 130-year period, and we can ask the question, well, what happened to the rate of spread of these 4 different influenza pandemics during a period of time when the extent of globalization and certainly human mobility vastly changed? And here's a nice visualization, not by us, we just cobbled it together from elsewhere, of how much human mobility changed over this period. This is what's called an isochronic distance map. It's a map of travel times rather than physical distance, starting in London, and it by a lucky coincidence, it happens to have appeared in an atlas that was published in London in exactly 1889, the start of the period of history that we're looking at. So that gray blob around London is where you could get within 5 days. The pink area around that is where you could get within 10 days. The yellow area around that, starting to embrace a substantial part of the world, is 10 to 20 days. And you could get to much of it within 1 month, but you can still see not to China, not to Australia, not to most of South America. A travel agency in Florida actually recreated this map for the year 2016, and now it looks like this. Still starting in London, that dark pink area is 12 hours. The light pink around that is 18 hours. The yellow, now hitting most of the world, is 1 day. So this is a 1 or 2 order of magnitude change in the speed of human mobility. And according to the best statistics we have, which we go through in the paper, the change in the volume of human mobility measured as travel, port arrivals, permanent migrants, is of the same order, somewhere between 1 and 2 orders of magnitude between 1889 and the year of the swine flu pandemic, 2009. Now, what happened to the rate of spread of these diseases? Well, here's a kind of graph that we've never seen anywhere else, and this is comparing the rates of spread country by country between the 4 pandemics that we look at, and then just as a reference in gray, we have the current coronavirus pandemic, which we don't study because obviously it's not over, and there do not exist final size measures, but by this metric of spread to country level exposure, we can put in a reference, that gray reference line. The horizontal axis here is the number of months since the start of international spread, that is, since the first day that the virus was reported outside the country of origin. So, for example, in the case of the Russian flu, it is the moment that it left the Russian Empire and was first reported in another country. And the vertical axis here is the fraction of the rest of the world's population that was living in a country that had been reached by the virus. And the definition of country in this graph is unique. It is a geographic area that is held constant over time. So this graph would end up being meaningless if the number of countries changed a lot, and what was one country in 1889 was 10 countries in the same geographic area in 2009. The populations here are actually demographers' estimates of the historical population of the of modern border countries. So in that sense, these curves are comparable. And the most striking feature to me is the horizontal line in the middle of the graph. That is the where that horizontal line at 0.5 hits each curve is the number of months after the start of international spread that the median person on Earth in the rest of the world outside the country of origin found themselves living in a country that had been reached by the virus. So further spread would be to them would be a domestic spread, not through an international mechanism necessarily. And what's astonishing to me is the narrow spread between all of these. That's a spread of about 6 weeks, about a month and a half between all 4 of these pandemics plus the coronavirus pandemic. 1 or 2 orders of magnitude change in the volume and speed of international travel. At the beginning of this, there were sailing ships. At the end, jet travel. And what's quite remarkable is that if you actually back out what the coefficient in cross section here looks like in terms of number of incoming trips and the delay you would get out of that, and compare it to the same very, very rough back of the envelope estimate that you would get from, well, how much of a delay would you get from reducing global travel by 1 or 2 orders of magnitude, they come out to a similar number. Now, that's not a dispositive test of any kind, because this is really n equals 4, but it's a notable quantitative coincidence that they both imply that a halving of global travel gives you about 2 weeks of delay. The second relationship that Thomas discussed, the relationship between arrival time and mortality, is it really true, as the model predicts, and as that epidemiologist told us, that whenever the pathogen arrives in your country, it does what it's going to do? There's no particular relationship between arrival time and mortality. So here are on the horizontal axis, this is for 2009 swine flu pandemic coming out of Mexico. The time of origin in Mexico is that vertical green line, and the vertical axis here is epidemiologists' best estimates, country by country, of the mortality, respiratory mortality from swine flu in all of the countries for which they were able to make estimates. Now, if it were the case that countries that staved off arrival of the virus longer had lower mortality, this would be a downward sloping line, and either in the linear fit or the non-parametric fit in the dashed line, we don't see any sign of that. A major limitation of these estimates is that most of them are imputed. These are the best estimates that epidemiologists have. They're very rigorously done, but they are made from a core group of 26 countries that report primary data. And based on other characteristics of the countries, including GDP per capita and such things, they impute mortality rates for the rest of the countries. And that leaves something to be desired, especially if later on, if we want to do things like control for GDP per capita in a regression using values that are imputed with GDP per capita, you're going to get nonsense. So because of that, we made our own excess mortality estimates that we were able to make for 99 countries. And for this, we just go into the World Health Organization mortality database, counting up mortality from influenza-like illness, ILI, which is a clinical term, and do a kernel regularized least squares fit for years just before and just after the years 2009 to 2010, and count excess mortality as the difference between true mortality from influenza-like illness in those 2 years and the regression line. And you can see from these selected examples of Chile, Israel, Belarus, Costa Rica that just in an eyeball sense, this method is indeed capturing a quantitative anomaly of influenza-like illness deaths that happened in those years. This is a test of the method. If you do the exact same excess mortality analysis for placebo years when there wasn't an influenza pandemic of 2004, 2005, 2006, 7, or 8, you get estimates that are not statistically significantly different from 0. But in 2009, you certainly get a big spike. So that's a verification of this epidemiological analysis being done by 2 people who are not epidemiologists. And when you put those numbers into the exact same graph you saw before, now the vertical axis here is not estimates that are imputed from excess mortality in 26 countries to the rest of the world. These are now direct measurements of excess mortality for all the countries where it's possible to do it from the World Health Organization mortality database, and the graph looks just the same. So this is an important robustness check on the mortality data that are out there. For the other 3 pandemics, there already are excess mortality-based estimates of mortality, country by country. So I'll just go through those quickly. Asian flu of 1957. This is the month of arrival outside of China, again originating in China, spreading first to Hong Kong, and from there to the rest of the world. And excess mortality, as estimated by historical epidemiologists, no relationship there at all. That is, once the pathogen arrives in your country, it does whatever it's going to do. Moving to Spanish flu of 1918. Again, it does not seem to be the case that countries that were able to stave off arrival of the virus for a longer period, you see Fiji, Chad, very remote Mauritius was able to keep it away for several months into 1919, did not have systematically lower mortality. People talk about Australia a lot, that staved it off for quite some time and had very low mortality, but it's certainly an outlier in the global sense. There is some this is for the fall wave of 1918, I should say, starting in August 22nd and probably in Brest, France, although there's some controversy about that. In the historical epidemiology literature, there's some question about whether the spring and fall waves of the 1918 pandemic were distinct pathogens, or at least driven by distinct pathogens, in the same way that now we're seeing different phases of the pandemic driven by the original coronavirus strain, or by the Brazilian, South African, or British strains. Now there aren't enough. There isn't enough surviving human tissue from that time to make a clear determination about that. So just we do a robustness check in which the entire 1918 pandemic's spring and fall wave are considered as a single pandemic event, as if they were caused by a single pathogen. And here again, just no sign of a downward slope, no sign that countries that were able to stave off arrival of the pathogen for a longer time were less harmed in the sense of final mortality. Last one, the quote unquote Russian flu of 1889. Here, the excess mortality estimates that have been made by historical epidemiologists are at the city level. and they've been done by, I believe, they've been done for, I believe it's 83 cities in Central Europe, Western Europe, and North America. And they do this just by taking weekly mortality estimates for these cities, gathered together from city records, and noting the big spike of deaths for any reason above normal deaths that happened during this a terribly deadly wave of disease. Here, the horizontal axis is the day of pandemic arrival, and again, this is outside of the origin region. Those estimates exist only for a subset of the 83 countries. So as an alternative for some proxy for the timing of the pandemic, we also use the peak week of the pandemic, which allows a much bigger data set, because such estimates, because a peak date exists by definition for all of the cities. And whether we use the reported initial date or the empirically observed peak date as the indicator of timing, there is not a statistically significant relationship between the timing and the mortality. These results to me are already saying a lot, that there is a small relationship between increased mobility and earlier arrival. There is not a detectable relationship between the arrival time and the final mortality in any of these cases. What we're really interested in, of course, is the relationship between mobility and mortality. But I do want to point out that just the results we've seen so far imply that if there were to be a substantial causal relationship between mobility and mortality, it would have to arise through a causal mechanism that does not accelerate arrival. And that's certainly difficult to think of. It doesn't mean it doesn't exist, but it's difficult to posit a causal mechanism that by which mobility would cause more mortality without making the pathogen arrive earlier. But for one of the pandemics, we have the data to directly test the relationship between mobility and mortality, as Thomas mentioned, and that is the swine flu pandemic. This is the simple scatter of immigration per capita on the horizontal axis here, and the respiratory mortality estimates of Simonson et al., who made those country level estimates of mortality, most of which are imputed. No sign at all of a positive relationship here of more immigration per capita being related with higher respiratory mortality. This is the same estimates using our own excess mortality based estimates, which are not imputed but are directly taken from WHO data for all of the countries. Again, no sign at all of a positive relationship. If anything, perhaps a weak and statistically insignificant negative relationship between immigration per capita and flu mortality. And again, these look quite similar if you have traveler arrivals on the horizontal axis. Last empirical result, and then let's turn to some discussion. Notice what we've been using as a proxy for final size here is final mortality, which is of course not quite the same thing. And there could be country level factors that mediate between final size, the strict definition of which is the fraction of population infected, and final mortality. So we do some very suggestive regressions. I'm one of those people, despite having committed the sin of cross-country regressions several times in my life, who thinks all cross-country regressions are at best suggestive, but we think it's suggestive in a useful way. Here is a multiple regression version of one of the scatter plots you just saw. On the left-hand side is final mortality as estimated by Simonson et al., mostly for imputed countries. And n equals 25 here. Why? Because we're throwing out all of the countries that are imputed and Mexico. And regressing not just on immigration per capita, but on some of the most basic country level characteristics that you might think could mediate between the number of infections and the number of people who pass away of those infections. Income per capita, urbanization as a proxy for the spatial concentration of people within the country, an index of healthcare access and quality. It's called the Healthcare Access and Quality Index, HAQI, compiled by the Institute for Health Metrics and Evaluation. And this is basically an index of a number of conditions that experts believe patient outcomes depend mostly on the quality of the health system. One of those is maternal mortality, for example, and it's an indicator of the ability of a health system to prevent a person from dying from a set of conditions in which patient outcomes are mostly determined by the quality of the health system. Now, unsurprisingly, in countries with greater healthcare access and quality as measured by that index, mortality in this pandemic is systematically lower and to a highly statistically significant degree. But I just want to point out that even after controlling for these things, and again, this is not a dispositive test, it's just an interesting robustness check. Even after controlling for these things, we don't see a positive relationship between immigration per capita and final mortality. Notice, since we're controlling for lots of things that we would expect to mediate between infections and mortality, the coefficient in red on immigration per capita now can be interpreted as closer to being the relationship between immigration and final size as measured by infections, because we are controlling away the causal pathway from infections to mortality, at least in part. And again, just suggestive results. Here, heroically stepping forward from n equals 25 to n equals 67, using our excess mortality estimates that are not imputed based on GDP per capita or anything else. They're all directly observed from data. Again, even after controlling for these substantial but not necessarily complete mediators between infections and mortality, no evidence at all of a statistically significant positive relationship between immigration per capita and final size. Here again, closer to an estimate of final size as infections than as mortality. So I just want to close with an analogy. I'll close with two analogies. One bad one that we thought of, and one better one that we saw in another paper recently about coronavirus. Thomas mentioned that the analogy that seems to spring to a lot of people's minds and asking, well, is there a negative externality from international travel is something like speed limits, that we've got to trade off the risks to life and limb from the convenience and from the economic benefit of the speed of travel. What our estimates suggest is that that's the wrong metaphor, that limits on international travel are something more like a speed limit on airplanes. That you can imagine a lot of if there were to be a spate of people dying in airplane accidents, that a politician could get on TV and say, I'm going to mandate that the cruising speed of passenger aircraft be reduced from 500 nautical miles per hour to 250 nautical miles per hour, and people might rally around that, but it's quite unclear that would have any effect at all on the rate of aircraft accidents. In fact, it might even increase the rate of aircraft accidents by keeping planes in the air longer as they travel more slowly. And I've never seen any evidence that the speed that the cruising speed of international aircraft in fact has an effect on the chance that you die in a plane crash. So it's that's an analogy we make in the paper. A simpler and much better analogy that we heard at the European University Institute when we presented this paper was from people who, unlike us, are studying the coronavirus pandemic and actually finding similar results in the relationship between the extent of exposure to international travel and mortality in the first wave of the pandemic, not the final size, but first wave mortality. Their phrase was just international travel is it might be the fuse, but it is not the fuel in the bomb. This is, I wish we had thought of it because it's the clearest expression of our findings that I can think of. That yes, it is undesirable for the fuse to be shorter and the bomb to explode earlier, but the force of the explosion does not seem to be related to the length of the fuse, and in this case does not seem to be related to the extent of international travel. We find that the ongoing permanent negative externality in terms of lives lost from international travel due to the pandemic mechanism is roughly approximated by 0. Thank you all so much. We would love to discuss any of this and work of yours on migration related or otherwise.
Excellent, Michael, Thomas, thanks so much. It's very eye-opening. And the good news is that mobility is not really a trigger of mortality. So hopefully, if this message is circulated wide enough, there won't be any sustainable restrictions on mobility and even migration after the pandemics. So the floor is open for discussion, questions, comments.
May I ask?
Sure, Bernard. Yeah.
Well, thanks both for the presentation. I hope that this information will reach more people, because it seems that it's becoming quite popular even now, like to make like tight travel restrictions. And very timely, like 20 minutes before the seminar started, like in Chile, my home country, they announced that they will close the borders almost entirely for 1 month. So, so well, my question is related to like these new variants that they are spreading. And so the argument for some countries that have been quite successful at vaccinating people, like the UK or Chile, is that they don't know how the vaccines will react to the new variant. So I mean, I'm aware that this is probably quite difficult to implement in the model, but what's your, let's say, feeling on like if this closing the borders has any sense, due to like new variants maybe spreading faster, and maybe you have vaccinated your population to the normal COVID, but maybe because of these new variants restricting traveling, maybe not closing borders, but at least having a system like New Zealand in which you quarantine people for 2 weeks makes some sense. I don't know if you have any thoughts on this.
Thomas knows I want to rant about this, but you start, Thomas.
Sure. Thanks so much, Bernardo. Thanks everybody. So the first thing I would say there, so we're looking at pre-pandemic mobility. You can think about I think it's interesting to think about the variant as being a potentially like different pandemic in and of itself, kind of in the spirit of your question. And then to think about the vaccines, I think is another interesting dimension. So the way I would think about this is what we've shown is like, well, what other epidemiologists have also shown, Scalia, Tamba, and Wallinga, is that even like the best restrictions are, they're not going to, they might delay the pandemic a little bit, but if you have kind of anybody coming in, there's going to be some kind of somebody getting in, and that it's going to take hold sooner rather than later. So if you thought that you were going to be able to vaccinate everybody like, tomorrow, and then, that there's a very clear antidote, for lack of a better term here, kind of coming in very soon, that kind of operates in the time scale by which this delay might buy you, then there may be some kind of advantages to that. But at the beginning of a pandemic, especially, that's really not the case, that the world that anybody's in, right? Even to find the most basic kind of, any solutions to, prescriptions, there's no vaccine, methods to treat this, that time window is just not going to be large enough. The time savings is not going to be large enough in order to kind of scale up those savings. So potentially, if again you thought you were going to be able to vaccinate everybody in the next week or two, then throwing up a bunch of travel restrictions there might be able to help. But it's hard to imagine the world that's in. The other case on New Zealand that I think is another interesting point. It's one a question we get a lot. So what New Zealand's case can make sense in our model. They did this obviously not before the pandemic was circulating, right? But even after there were already cases in New Zealand, that was part of a broader kind of strategy, which incorporated domestic restrictions and international travel restrictions, and had a massive negative impact on, many of the New Zealand economy, New Zealanders that wanted to come back to New Zealand. And so wouldn't be a strategy that you would want to adopt more widely in order to prevent the next pandemic from coming. So we're not saying in a case like New Zealand, that seems to be part of a suite of strategies that was effective at protecting the two domestic islands, but wouldn't invalidate kind of the wider findings on thinking about the next pandemic and about travel restrictions kind of more broadly. So, Michael?
Yes, well, I just wanted to reiterate something we were talking about earlier, which is this most basic epidemiological results, which has been around since 1926, that the final size in any given country is fully determined, mechanistically determined under core assumptions by R0, the reproduction rate in the country. That is determined by all kinds of things: the population density, the degree of mixing of people, commuting patterns, how many occupations are face to face, whether people are masking, whether there are social distancing guidelines, how many concerts are going on, et cetera, et cetera. That has no role at all for the rate of introduction of new exemplars of the pathogen into the country. In other words, very, very early on, during exponential growth of the pathogen in the population, filtering through at whatever R0 is determined by all of those domestic traits, your chance of encountering the pathogen in a native circulating around you is very quickly vastly more than in encountering it via a traveler. And the quintessential example of this, as we were talking about before, but not everybody might have heard, is Thailand and the United States. And these are two countries that are right on the regression line of our results. Thailand, before the pandemic, had roughly twice as many arrivals from China as the United States. If you just stick that into our regression, that would tell you that it should have, the pathogen should have arrived in Thailand 1 or 2 weeks before the United States. That's exactly what happened. It was, in fact, 1 week earlier, January 13th, compared to January 20th in the United States. But the second part of the model is once the pathogen arrives in your country, it does whatever it's going to do. So Thailand took drastic measures recommended by international public health authorities to quash the virus and make sure that R0 was below 1. When R0 is below 1, there is no pandemic. There are fewer infected people than 1 is generated by each infection, meaning it dies out. That is what happened in Thailand. In the United States, it exploded with hundreds of thousands of deaths all around me as we speak. And the mortality rate in the United States is 1,000 times the mortality rate in Thailand. So here's a country that was much more connected to not just internationally in general, but directly to the origin country of the virus, with 1/1000th our mortality rate. That is an exemplar of final mortality being determined by the domestic forces that controlled the domestic reproduction rate. And if I can just take a moment to mention Konstantin's question in the chat, asking, can your conclusions be extended to the intra-country limitations on freedom of movement during epidemics? Certainly not. The R0 within a country is determined by things that include movement. So this is not at all saying that physical lockdowns or prevention of commuting to work, or requirements to work from home, or social distancing, or limitations on the use of public transit, all of those things within countries that are the internal counterparts to limitations on international travel. Those things determine R0. And R0 determines the final size. So certainly those things are a critical determinant of how many people die. And it's precisely the fact that that Australia and New Zealand and Vietnam and Thailand and Taiwan and many other countries did those things to get R naught below 1, which eliminates the pandemic by definition. Domestically, that is the reason why when people who are now young are asked there years from now, where were you during the pandemic? They'll say, what pandemic? Whereas people who were young, like my children in the United States, will talk about how their lives were changed by the pandemic. It had nothing to do with international travel, and it's counterintuitive, and it's not just counterintuitive, but it's a misunderstanding of fact that has been misused for political purposes in the United States, most notably by the president of the United States actually crossing out the words coronavirus in a speech he was giving at the White House and replacing them with the Chinese virus, because he enjoyed, for political purposes, associating the virus with foreigners and travel and globalization. But it's simply not supported by any evidence we have.
Okay.
Sorry,
sounds good.
Quick question related to what you said at the end. Like, are you aware of any studies or any other anecdotal evidence on countries who have been relying a lot on closing borders rather than other measures, this being related to native attitudes towards migration? I don't know, in countries where the population is against migration and then their leaders decides to close the borders because it's a popular measure rather than being actually an effective measure. Are you aware of any studies or any sort of evidence about that?
But I do want to stress, and Thomas, feel free to chime in, especially if you disagree. I want to stress that I don't think, I think there is a key role for emergency travel restrictions during the pandemic, when we know that a pandemic is out there and has a high probability of arriving with any additional traveler, but exclusively in combination with measures, with domestic measures that get R naught to 1 or below. That is, if you're going to do what the United States did, and it's maintain a situation where the grass is dry and hot and ready to explode at any moment, then decreasing the number of international travelers by 50, 90, even 95% is not going to help, because within a few weeks somebody's going to arrive anyway. The spark is going to land on the grass, and the grass is going to explode in flames. So as a strategy for preventing final mortality by itself, emergency travel restrictions are not useful. That's an implication of our results. It is not an implication of our results that they have not been useful to New Zealand. New Zealand took combined emergency travel restrictions with highly effective domestic measures, killing the pandemic by getting R naught below 0, allowing behind a wall of emergency travel restrictions those domestic measures to be lifted. People could go to concerts again, universities could hold classes again, and in that environment, while the pandemic is circulating, it could be that continuing emergency travel restrictions ensure that another explosion of grass fire doesn't happen as a short-term measure until the pandemic ends. But at some point, we must return to a world in which university classes do meet, offices exist, public transportation is used. And in that world, travel restrictions by themselves have no role, which is why our case is against permanent travel restrictions of any kind. Unless, of course, the world reverts to some sort of a virtual reality in which we all work at home permanently. And in that case, there may be a role. In that case, the whole world becomes New Zealand. And that doesn't sound like a world I want to live in.
Can I just follow up on that, just a slightly different take, Bernardo, on your question around public attitudes. So in one seminar that we gave earlier at the Migration Policy Center, and I'll put a link to this in the chat here, our discussants for this paper, Ellen Immergut and Daniel Fernandez, they correlated, I forget the exact kind of specification in the sample and that kind of thing. But anyway, I thought it was very interesting. And I think, if I'm not getting this wrong, what they found was that the restrictions actually, like people's opinions of the effectiveness of their government's response to COVID were strongly linked to the number of domestic lockdowns and domestic policies, but not to international policies and lockdown, like travel restrictions and things like that. And so it kind of tied together nicely with our findings in that, like, the domestic, like people's perceptions that the domestic policies are actually what's going to kind of make or break your response. Even if politicians thought that their populations would react well to, okay, just keep out all the foreigners, like this is a foreign disease, just lock down the borders and we'll be fine, that actually the correlation was stronger with domestic policy restrictions than it was with foreign restrictions. I could be getting that wrong. I just posted the YouTube link. They were the discussants at the end of our talk. I haven't seen them publish that anywhere, but I thought it was very interesting, and I think related to your question as well.
Thank you very much.
Good. Okay, let's see if there are any other questions or comments. We still have a bit of time for that. Well, if I may, while people are still thinking, you said at the beginning that one of your questions is whether it's worthwhile to put permanent preventative ex-ante restrictions on international mobility and migration as a means to reduce pandemics. And it appears that there is no empirical case for that. Question is, how about these restrictions ex post? That is, when there is a news that there is some virus around. In that case, putting some restrictions, as I said, ex post might help. And the second question, if you will, which is to continue on what Konstantin asked, I think that's an important question. Is there any evidence that domestic restrictions complement or substitute for international mobility? In other words, do they act independently from each other, or the effectiveness of international travel restrictions depends on what you do domestically? You can please comment on this. Thanks.
Thomas, do you want to take the first one? You heard me ranting a lot.
Sure. Yes. So the question of ex post travel restrictions, I think first, we would not say that we're bringing empirical evidence to bear necessarily on that question. Our regressions are mobility in the year before and not mobility during the year after. So we're going to kind of talk outside of the data here. But the closest thing I would say is kind of point to the model that we had when we kind of relaxed that restriction in the model and say, well, even if you were to allow travel to continue in most kind of parameters, reasonable parameters of the model, that the proportion of foreigners that you're going to be interacting with once the disease is already prevalent in your home country is going to be very small. The number of foreigners incoming are just going to be a very small driver of the number of infections overall. And so you can imagine this varying a little bit at different stages of the pandemic. They may accelerate it faster at the beginning. They might kind of prolong it a little bit at the end and kind of change a little bit the evolution over the course of the pandemic. But overall, I don't think that there's much evidence to say that even like during the pandemic that we would necessarily on their own, which relates to your other question that I'll let Michael tackle, that on their own, that just international travel restrictions that aren't complemented in a situation like what New Zealand is doing have been effective at keeping out either new variants or kind of the original disease. So even ex post, again, if we're just kind of like, what's our best guess for this? And I think that's also consistent with what the WHO has been saying, what other epidemiologists have been saying, and that like international travel restrictions oftentimes may have more negative effects in terms of vaccines being able to get where they need to go, doctors being able to move around, and like efficient allocation of resources in response that would have possibly, the argument is as good that the net effect would be negative as it is that it would be positive, even if that's our knee-jerk reaction. So that would be one take on it, but I wouldn't kind of, I would want to do much more if I were the head of the WHO or president of a country before I would want to make that recommendation during a pandemic. But Michael, let's take a second.
So the second question, if I understood it, Professor Polishchuk, was Konstantin's question about domestic mobility. The core theoretical results, and here we're just consumers of the epidemiology literature. We don't claim to be epidemiological modelers at all. They're called patch models in epidemiology, and there's been theoretical interest in mathematical biology and epidemiology about whether if an epidemic is happening not within a single perfectly mixed country population, but within geographic patches of a country, with the example in the literature being US cities, where each one is a patch, does the degree of mobility between those patches affect the final size? And the theoretical result, which takes paper after paper to prove, but is really quite intuitive, is that if the reproduction rate is the same in each patch, then the degree of mobility between them does not affect the final size at the national level. And intuitively, within each patch, the reproduction rate fully affects the final size. So if everybody has the same final size, as Thomas showed on a 2-country graph, the amount of circulation between them is not going to increase or decrease the probability that any given person you run across in the street, whether from your patch or another patch, is infected. So there would be a justification for barriers between patches of a country to the extent that R naught is different in different patches. And in a country with a functional national government, in which a category in which I would not place the United States last year, where there were extreme regional differences of policy, where some governors would say everybody must wear a mask, and other governors would say actually nobody must wear a mask. And you could have very substantial regional differences between these quote unquote patches in R naught. That would imply an epidemiological justification for emergency travel restrictions between patches, between US states. And in fact, those exist. If you want to go to New York to New York State from a US state that is not a neighboring state at this moment, so if you want to go to New York from New Hampshire, but not from Vermont, because Vermont borders New York and New Hampshire doesn't, you have to quarantine for 2 weeks. That is a domestic restriction on mobility between patches, and there is a justification for it in that it could, in theory, affect the final size in New York. A nice way of saying it could kill people in New York. But if you have a homogeneous national policy of school closures, of mask mandates, of social distancing, of transit restrictions, that would obviate the need, in theory, for any sort of domestic travel restriction.
Okay, that's clear. Thanks very much. Let's see. Any other further comments? Well, I would summarize the talk by saying that not only all politics is local, but also all pandemics are local, right?
Well
and
done.
we would like to thank you very much, Michael and Thomas, for an important and thought-provoking presentation. We hope to see you again at the Higher School of Everything before too long, virtually and physically. And yeah, please, you want to say something, Mike?
I wanted to thank you very much for hosting, and also very much to Bernardo, who emailed us out of nowhere this a very kind, very open email saying, quote unquote, come to Moscow and present, and it's our great pleasure. Thank you.
Thank you so much.
Bernardo is known for fetching up very good speakers, and that reminds me of our next seminar. Bernardo, who is
First, thanks, Michael and Thomas. It was very nice to have you today here. And
our pleasure.
Next week, we will have Amalia Miller presenting her paper titled Effects of the COVID-19 Pandemic on Domestic Violence in Los Angeles. So we will stay around the same topic for one more week. So, same time, same place. We hope to see you all with us. Good luck, Thomas and Michael.